Good morning, ladies and gentlemen. Good morning. Nice to see your wonderful faces this morning. I'm Liz Tonjira. I'll hand over to Abel to take us through something small before we officially start.
Absolutely. Thank you very much, Liz. Hey, hello, good morning. Yeah, that's more like it. Actually, let's stand up for do something kidogo hapa. Kidogo tu. Tuchangamke kidogo. Ama namna gani? Yeah? Is your day coming along fine so far? Iko sawa? So I want us to play a little game, 1 minute max, okay? So your right hand, I want you to point up. Yeah? On your left, yes, Senator Malago, I see you. So the left one, put a roof on your neighbor's index finger. No, index finger. Yes, put a roof there. On your right or left? Is it? This is left. Yes, on the left. We're in business. Now, the aim of this game is to make sure that they don't get a hold of your finger. Yeah? Usikubali kuwekwa kwa mkono. Usikubali. So, at the count of 3, nikisema tu 3, toa hiyo mkono hapo kabla akushike. Okay? Sasa, we'll do a trial run. All right. 1, 2. Bado. Okay. 2. 2.5. 2.5. 3. Aya! Nani amenaswa? None! You need to be fast, guys. Be fast. Let's try it one more time.
Hii raundi nasa mtu. Usikose kunasa mtu. Okay. So are you ready?
Yeah.
All right. The count begins now. 3. Oh, umenaswa ukaunasa. Thank you very much, guys. Sit down.
We warmly welcome you to this pivotal side event during this Devolution Conference 2025 in Homa Bay County. My name is Liz Tonjira, the co-chair of the ZMCC, the Zero Malaria Campaign Coalition, and we'll be co-hosting this session with Abel Mutua, who's popularly known as Mkurugenzi, and we'll take you through this brief session this morning. Today, we are gathered with shared purpose to explore and delve deeper into public-private partnerships and collaboration models that can transform healthcare delivery at the county level across Kenya and permeate to the national levels. This session comes at a crucial time when counties face unprecedented funding gaps following reduction in official development assistance and shifts in donor support. It is also a moment to celebrate and learn from the remarkable success that has been achieved here in the county of Homa Bay. As we embark on this journey together, we acknowledge the traditional protocols and honor the presence of our distinguished leaders who have championed health reforms and stood tall in the face of challenges and public-private collaborations to ensure universal access to quality healthcare. This session aims to provide a comprehensive understanding of public-private collaborations, or best known as PPPs, to debunk myths, share real experiences from counties like Homa Bay, Tharaka Nithi, Nakuru, and Kajiado, and importantly, co-create innovative financing and governance structures that will sustain Kenya's health sector under devolved governance.
Wow, beautiful, Liz. Check. Iko sawa. Can you hear me? Oh, nice. Yeah, just like Liz said, my name is Abel Mutua. I am a filmmaker, actor, and storyteller. But what most of you might not know is that I am the Zero Malaria Ambassador, Kenya. In fact, yesterday I put up a poster that I was going to be here today And one of my friends called me with a lot of excitement and he was like, "Aya, bra, sasa wewe umeingia kwa maziwa wewe. But niko na swali. Mkiweza kueradicate hii malaria, inamaanisha kazi yako imepotea hivyo?" And I was like, actually bro, let me just remind you that we lose a child every minute from malaria. So if changing that will come at the expense of my job, then it is a sacrifice I am willing to take. Ama namna gani watu yangu? Yeah. And I know for a fact for that to happen, we need a robust healthcare system, despite the challenges that we are facing. Juzi muliona, the American government withdrew, but that doesn't mean that we should now sit and just wait to die. No. We must adapt. Yeah, we must adapt. And one way of adapting is exactly what we are doing here today, fostering public-private collaborations that make sense, okay? And just by looking at the partners in the house tonight, I know for a fact that we have exactly what it takes and exactly who it takes to deliver us to Canaan. Sindio? So sisi as media people and storytellers, our work is to ensure that we shape the narrative, to ensure that whatever is discussed here is put into action. Sawa sawa dau. Thank you very much for coming through. Nyinyi ni watu wa nguvu sana. I am hoping we will have the best conversation and engagement up here, Miss Liz Ntonjira, au sio?
Kabisa.
Hapo sawa.
Thank you so much, Abel. I know we'll switch the program a little bit and we'll start with the presentations and highlights from the different counties, just to learn about what have they been doing in terms of malaria elimination, what are some of the opportunities, what are some of the threats, what are some of these milestones that they have achieved as they try to conquer malaria. And I'll invite Dr. Noel Orata to take us through that.
Good morning. Welcome. My name is Dr. Noel Orata, the Ecosystem Design Lead at Open Phences, and one of your hosts today. We really hope you
a bit with. Yeah, but seriously, welcome to Homa Bay. Okay. So I'm going to speak to you about our Daktari Smart telemedicine program. Daktari Smart telemedicine program is a PPC by M-Pesa Foundation, Gertrude's Hospital Foundation, and of course, Homa Bay County. This is a hub and spoke model that is implemented in 5 counties, 6 health facilities. The 7th unit is a mobile unit that conducts outreach all across the 5 counties. In Homa Bay, TeleSmart, the telemedicine project is implemented in Super South sub-county. This project targets people from the age of 0 to 21, and I'd just like to draw your attention to the fact that we have 44.2% of the population at 65,700 under the age of 15. So very, very many people targeted by this program. The program was launched in 2021 to improve access to specialist services in rural and underserved areas. It uses technology to deliver consultation and care in real time. This project offers specialized pediatric care. The most sought after is hemato-oncology and dermatology. This project has helped to strengthen our healthcare system. It has improved our health workers' knowledge of pediatric care. Our community mobilizers are well-trained and well-versed in care for children. And there's been a lot of advocacy with local stakeholders improving the quality of care for children. 5,545 children have been seen at Super Sub-County Hospital, 2,600 of these in outreach. This is like a camp, almost like a medical camp. 17 children have received specialized advanced service, including open heart surgery. This is what the TeleSmart medicine, oh, it's not moving. It is? Okay. So this is what the project looks like. You have a monitor and a doctor on the other side, a specialist. We have several gadgets that we use on this other side, and you can see there's on the CINDO side, we have a patient, we have a healthcare worker, and we have a gadget that shows them what is happening on the other side. This project was really to address one gap, one major gap, the lack of accessibility and affordability of specialists. This program has solved that problem by allocating specialists on a regular basis, strengthening the capacity of healthcare workers, training community health promoters. In terms of financing, the project is funded by M-Pesa Foundation, implemented by Gertrude's Children's Hospital and County Government of Homa Bay. The total cost for setup of each facility is $53,000 US. Annual operating costs at the moment of these facilities are $32,400. Telemedicine consultations cost 2,200 shillings for a regular pediatrician and 2,600 for a specialist. Those of our patients who have been registered on SHA have been able to continue their consultation and their patient's journey through through SHA. I won't go into the breakdown of the costs. The telemedicine project is aligned to all the major policies. Now, something interesting about this program, the doctors at Gertrude's actually see both live and virtual patients. So when our patients come to the facility, they join a queue. This sometimes is a problem because the queue is very long. The doctor sometimes focuses on the patients who are in front of him or her as opposed to the ones online. And sometimes the doctors recommend tests that take time. Welcome, Your Excellency. Your Excellency, with your indulgence, I'll continue with the presentation. Yes, so a major issue that we have is delay in time because sometimes the doctor is very busy on the other side with live patients, or the doctor requests certain tests that are not available readily and the patients have to go back home and come back, and sometimes they cannot afford those tests. The other challenge is the scope. The project does not cover everything. It doesn't cover pharmaceuticals, diagnostics, or even transport if somebody requires specialized care to Gertrude's. From an operational side, we're looking at scaling up, expanding services by creating additional hubs and spokes, such as in Diva Sub-County, where we have a huge burden as well. And we're really laser focused on sustainability, resource mobilization, strategic partnerships, leveraging SHA, and developing a lower cost operational model. So looking forward, the program has been extended by 3 years. Initially, it was ending in 2025, again, targeting an additional 5,500 children. Last year, we established a transition committee, anticipating that the program was going to end, and we will continue to work on that transition committee because resources have gone down anyway. In terms of sustainability, we're looking at integrating Daktari Smart into routine service provision and some of the digital innovations that we're already implementing in Homa Bay. I welcome you to our stand, our pavilion, to learn more about that. We're looking at developing a lower cost operational model that involves using our own specialists, our own pediatricians here at Homa Bay County Teaching and Referral Hospital. We're looking to mobilize and leverage SHA to support consultations. We're looking to resource mobilization, focusing specifically on partners that support some of the gaps, like specialized treatment for the indigent. And we're looking at developing a governance policy that supports institutionalization of telemedicine. Allow me to acknowledge the team from Gertrude's who are here in the room, as well as our county staff who work on this program. Thank you very much.
Thank you so much. I want to break and allow protocol to continue, I want to introduce my governor, Homa Bay County, Her Excellency Gladys Wanga, to come and give us her words today.
Thank you, Daktari. And thank you for being a bright girl from Homa Bay. Good morning. Welcome again to Homa Bay. And I hope that so far so good and that you are enjoying yourselves. Every 2 minutes somewhere in the world, a child dies from malaria. For decades in the Lake region, the statistic was not just a number, it was our reality. Families here buried children before they ever celebrated their 5th birthday, and expectant mothers lived in constant fear. But in Homa Bay, we have decided that statistic will not define us. Kenya is a nation of immense beauty, resilience, and potential. Yet within our borders lie stark disparities in the health burdens our people face. While some counties have successfully eliminated malaria, in others, especially in the Lake region, it remains a relentless public health emergency. In Homa Bay and across our neighboring Lake counties, malaria was for decades one of the leading causes of sickness and death. The most vulnerable were always the same: children under age of 5 and expectant mothers. Every case was more than a statistic. It was a child missing school, a family pushed deeper into poverty, and a dream interrupted. When I assumed leadership, malaria prevalence in Homa Bay stood at a staggering 17%. It was clear that business as usual would not be enough. We needed urgency, innovation, and unity of purpose. Today, I'm proud to say that through collective action, deep community involvement, and unwavering support from our partners, we have brought this figure down to just 3.6%. This represents thousands of lives saved, hospital beds freed, and communities thriving. This success did not happen by chance. It is the product of deliberate, targeted interventions that reached every corner of our county. Mass distribution and timely replacement of insecticide-treated nets, IRS in high transmission zones, strengthening diagnosis and treatment with rapid diagnostic tests in even the most remote facilities, and a robust community health strategy, empowering local champions to lead prevention, early detection, and treatment, and strong surveillance and research systems to anticipate and respond to outbreaks. Our journey has been made possible by a coalition of committed partners: the Global Fund, USAID's President's Malaria Initiative, they wound down, WHO, UNICEF, and the Bill and Melinda Gates Foundation, and our local civil society organizations. They brought not only funding, but also technical expertise, innovation, and an unwavering demand for accountability. It has been a model of what happens when government leadership meets community ownership and when local action is matched with global solidarity. Yet even as we celebrate, we must confront the sobering reality that the donor basket is shrinking. Actually, this is the first side event I am speaking at in this conference. Because I didn't realize that when you're a host, you miss the conference itself. But I decided to confirm and come because Dr. Rata and the team told me about how we must move to private sector, partnerships to be able to cover for the gaps that we are now facing with moving out of the donors. Dr. Nyikal, I've seen you right there, our chair of the Health Committee, Senator, Governor Senator Mandago. I thought you wouldn't make it, but given our activities of last night, but karibu sana, even Dr. Ganda, I didn't think you'd be here. The way I saw you throwing your legs, but It seems like we are able to multitask. So, if momentum fades, malaria will reclaim lost ground. And the gains we have made, paid for in dedication, sacrifice, and lives, could be reversed in just a few short years. Malaria is unforgiving, and complacency is costly in both human lives and economic productivity. That is why we must be bold in mobilizing domestic resources and innovative in financing our health responses. The fight against malaria cannot be sustained by donor funds alone. It must be anchored in stronger health systems and public-private collaboration. We must build resilient primary healthcare facilities equipped with skilled healthcare workers, reliable supply chains, and digital health tools that can detect and respond to outbreaks faster than ever before. A health system that is strong for malaria will be strong for all diseases. At the same time, the private sector has a critical role to play. From investing in mosquito net manufacturing and local pharmaceutical production to financing innovative vector control technologies, supporting workplace malaria prevention programs, and funding research. Here in Homa Bay, we're exploring models with private sector players, models where private sector players co-invest with county government in community health units, diagnostic capacity, and continuous training for healthcare workers. This is not charity. It is a shared value. A healthy population is the foundation for a thriving economy and a productive workforce. I stand here not just as the governor of Homa Bay, but as a daughter of this region and as a zero malaria champion for the Lake region. I call on our fellow leaders, our development partners, the private sector, and our communities. Let us keep our foot on the pedal. Let us ensure that the next generation inherits a Kenya where malaria is not a daily threat, but a story of the past. We have proven that progress is possible. Now we must prove that it is sustainable. Together, we can end malaria in our lifetime. And when we do, it will not be because of lack, but because we chose to act decisively, collectively, and relentlessly. Thank you very much. And I'm happy to have added my voice to this conversation. Last year when we had the Hobbik here, I was named by AMREF as the champion for getting to zero malaria. But I was telling them the other day that after being named, it just ended there. So I'm happy that today I can perform my first duty as the champion of malaria by speaking at this very, very important side event. Asanteni sana, and God bless you, and I wish us all a good side event, and I hope that the resolutions we have here will not remain here, but will be put into action so that we get to zero malaria. Asante sana. Thank you very much.
Thank you. I want to bother you. I want to put for you a tag in honor of no malaria in Homa Bay. Thank you so much. In observation of protocol, we'll move on with the program. And I would like to invite Engineer Kefa Seda, the Head of Directorate Public-Private Partnerships at Treasury. I will allow Her Excellency to greet her guests and our guests. Thank you.
Her Excellency Gladys Wanga, Governor, Homa Bay County, Your Excellencies, Deputy Governors who are present with us here today, Senators who are present with us today, Members of Parliament who are here with us today, ladies and gentlemen, good morning. Good morning once again. Breakfast hatujakula? When I heard Her Excellency talk about malaria, it took me back to the 1980s. Malaria was such a dreaded disease because, for one, if you'd get it, you'd fall sick, isn't it? And then there was these drugs that were brought into the market. Taking them was also another dreaded episode because they were too bitter to swallow. And then lastly, after swallowing, I don't know what Dr. Jikal did to those drugs. You'd sit in a corner and wait for your body to do what? To itch. That was malaria queen, chloroquine, and such like. So, Daktari, you will tell us what you did with those drugs to make us itch. So, taking us back to what has brought us here today, as I've been introduced, my name is Engineer Kefa Seda, Director General at the PPP Directorate at National Treasury. And I'm happy today to participate in this discourse, speaking about healthcare, collaboration between public and private entities in healthcare systems. It is both an honor and a privilege to join you today for this important session on the institutionalization of public-private partnerships in healthcare across counties. First, I would like to express my sincere gratitude to Open Phences for inviting me to contribute to this crucial conversation on healthcare within our devolved units. I would also like to commend the Council of Governors for organizing the Evolution Conferences, which is a vital platform that fosters collaboration, idea sharing, and innovative solutions among counties. The theme of today's session, healthcare, financing, equity, and inclusion, lies at the very heart of our ongoing journey to devolved governance. As we face challenges of shrinking fiscal space, and this is something that we speak to on a day-to-day basis, and mounting unpaid bills, the goal remains clear: to ensure affordable, accessible, and high-quality healthcare for all. In times when both national and county governments are grappling with these financial constraints, our commitment remains unwavering. Every Kenyan, regardless of geographical location or economic status, must have access to quality and equitable healthcare services. This vision drives the Public-Private Partnerships Directorate at the National Treasury to provide legal and regulatory framework that supports collaboration, partnerships amongst national and county governments, and the private sector for collective efforts of improving healthcare outcomes across the country. So why do we go for PPPs at the county levels? Counties face a complex reality. While the constitutions guarantee the right to health, limited budgets, competing priorities, and growing service demands often strain available resources. The public-private partnerships offers a way to ease the pressures, not by replacing public responsibility, but by leveraging on private capital, expertise, and innovation to enhance and expand county health systems. Do we have opportunities that exist for healthcare within as PPPs? Yes, through PPPs, counties can, 1, build and equip modern hospitals and specialized units, 2, expand diagnostic, telemedicine, and mobile clinics to undeserved areas, 3, strengthen supply chain for medicine and vaccines, and lastly, improve patient records, systems, and referral networks through digital health solutions. We have already witnessed promising opportunities emerge. And the examples here we are talking about is the Meru County government, where we want to put up a 50-bed facility for cancer patients. We also have the Pwani University Teaching and Referral Hospital. Then we have the Moi University and Kenyatta University, where we're trying to explore the use of PPPs under the PPP Act in adopting competitive methods to develop the following healthcare facilities. So in Meru, as I did allude to, we are working on the development of the state-of-the-art 50-bed cancer facility at Meru Teaching and Referral Hospital. This facility will feature anatomic pathology and medical imaging capacity, offering critical services such as chemotherapy, radiotherapy, surgical treatment for cancer patients. In Pwani University, we are developing a Pwani Teaching and Referral Hospital, which is a 200-bed capacity facility. But because of affordability, we are starting with a 450-bed, and we'll graduate it up to 2,000-bed capacity. And the project will include Center of Excellence in Health Management and Research, Tropical Medicine Center, Center for Telemedicine and Informatics. Additional components will include features of a cafeteria and eateries, students' hostels, doctors' plaza, staff housing, and administrative block, a gymnasium and recreation court, and a transport center. In Moi University, what we will be doing is to expand the Moi Teaching and Referral Hospital with enhanced teaching and student accommodation facility for the College of Health Sciences. The new teaching facility will accommodate up to 3,000 students, and the accommodation facility will house up to 800 students. The expansion will include library, skill laboratories, conference halls, amphitheaters, ICT resource centers, and retail areas. In Kenyatta National Hospital, what we are trying to do is to develop 2,500 residential units to meet the housing needs of critical staff. The accommodation will range from studio to 4-bedroom apartments and will provide housing for families and patients' caregivers, with fees deducted directly from the staff payslips. These examples remind us of that PPP are not abstract concepts. They can deliver tangible improvements when well-structured and community-focused. I believe we all watched the PPP symposium, where we showcased a number of projects that are working, ranging from all sectors, be it transport sector, be it health center, be it on accommodation, be it on even the transport related. You talk about airports, you talk about seaports. PPPs work. The realities and challenges we face, which we must candidly address to deal with. We have experienced a lot of project stalls when incoming administration changes priorities every 5 years. This disrupts momentum, sometimes requiring us to restart engagements entirely. At county level, lack of dedicated, experienced PPP teams has been a barrier. Without consistent institutional memory, projects lose direction, negotiations slow down, and timelines stretch. And we are there as a PPP directorate under the National Treasury. Besides supporting the national government, we are offering this hand to support the county government. For those of you who read and have interacted with the pieces of legislation, the PPP Act of 2021, from Section 64 all the way to Section 65, provides for mechanisms on how to onboard PPPs at the county level. And this does not only speak to health, it speaks to all sectors within the county. So if you're available, you have concepts that have been prepared, please don't hesitate to reach to us as a directorate, because it also provides for mechanisms through which the directorate can support you in all phases of the PPP life cycle. Pathways to institutionalization and scale. To address these challenges, we need to embed PPP processes within county institutions so that projects survive political transitions, invest in training and retaining skilled PPPs and health project teams at county level, align county and national PPP frameworks to avoid duplication and confusion, explore blended finance and results-based models to make healthcare PPPs bankable. And lastly, share knowledge and case studies so that counties can learn from each other's successes and avoid repeating mistakes. Equity and inclusion at the core. Institutionalizing PPPs is not just about financing. It's about who benefits. Projects must prioritize access for rural, marginalized, and low-income population. They must integrate gender and disability considerations from design to delivery. And they must embed affordability safeguards so that no Kenyan is excluded from the essential healthcare because of cost. When equity is the guiding principles, PPP becomes not just partnerships for infrastructure, but partnerships for justice. So what is the way forward? As a PPP directorate, we stand ready to walk this journey with counties, providing technical support, helping structure bankable projects and impactful healthcare projects, and ensuring that every partnership serves for the public good. Let us move forward with a shared commitment, start small, learn fast, scale smart, and above all, keep the citizen at the center. Together we can build a healthcare system where every Kenyan in every county has access to quality, equitable, and inclusive healthcare. Asanteni sana.
I want to break protocol because we need to release Her Excellency. In our session, we had a special Homa Bay statement, which is just looking forward on how we can go about PPPs. It's actually not political, it is progressive, looking at how we can foster partnerships in all counties in Kenya. So we'll have a few select individuals come and sign, and I think Professor Frank Wafula is going to lead this process.
Thank you very much. Good morning, everybody. Yes, so the Council of Governors has something called Marifa, which is a platform that is supposed to foster learning across counties. But I know the Council and Madam Nutis, they would actually like to see that dream actualized. One of the things that you're going to see as these sessions continue is counties are doing amazing work when it comes to partnerships. But one county does not know what the other is doing. So what we are doing here, Your Excellency, is a statement of intent to establish a mechanism that allows counties to learn from each other on public-private partnerships and investments so that they don't repeat the mistakes. Because sometimes what happens is this one has done this, they made the mistakes, they corrected it, and then somebody else starts and they start from the mistakes. So this is just a way of actually getting that commitment out. But the most important thing in this commitment is we are proposing. Those of you who are familiar with the National Council Law for Science and Technology Act, it says that 2% of GDP should go towards learning and research. What we are proposing here is, as partners who work with counties and government, can we progressively aim to allocate at least 2% of project value to support learning and discussions towards scaling so that we stop doing small things and then moving away. So as partners, we can actually have some resources put aside. So it's purely a symbolic signature to support the county, the Council of Governors and partners to establish a joint learning mechanisms for PPPs. And yeah, so I'm going to ask for symbolic signing purposes that the signing mandates that are presented there be signed. Yeah, starting with Your Excellency, on behalf of the Council of Governors. The photographers, I hope you... Thank you very much, Your Excellency. Let's give her a hand. Then we have on behalf of the PS, who had traveled to Zambia. And then Honorable Governor Mandago, on behalf of the Senate Health Committee. And then Dr. Nikal, our mentor, on behalf of the National Assembly Health Committee. And then Dr. Gakombe, the chair of the Kenya Healthcare Federation, the umbrella body for the private sector, on behalf of the private sector. We are going to ask Dr. Bernard Olayo, who is perhaps the partner who works with the World Bank and leads the PPP work within the bank, to sign on behalf of partners. And ladies and gentlemen, I was requested to sign on behalf of learning institutions. So I'm just going to walk down. Thank you very much. So as a last request, I would like to request, and obviously as the governor upstands as well, we can just take one photo as we release you. And thank you very much to everybody for witnessing this as well, which means...
Thank you very much. I think we have to give Her Excellency grace because she's hosting everybody. And so we apologize, but we had to interrupt the normal scheduling of the program to accommodate the signing, which was very important as an adaptive learning mechanisms of PPPs in Kenya, leveraging on each other's strengths and learning from each other's challenges. So I want to move on. We have a representative from the Office of the PS, Ministry of Health, Mary Muthoni. Dr. Terry Kamau will give us her words in a few minutes.
Your Excellency, Our Lady Governor Gladys Wanga, she has moved out. Distinguished guests and dignitaries, ladies and gentlemen, good morning. The Principal Secretary for the State Department for Public Health and Professional Standard, Ms. Mary Muthoni Muriuki, sends her greetings and also her apologies for not being able to come and attend this side event in person. But she also sends me to deliver her speech on her behalf. My name is Dr. Terry Kamau. I'm the project manager, Building Resilient and Responsive Health System World Bank project with the Ministry of Health. If you allow me, I'll read her speech. It gives me great pleasure to preside over the official opening of this side event, specifically curated to discuss expanding investments in healthcare and public-private partnerships. I sincerely thank each of you for taking time to come and participate in what we hope will be the first of a series of similar engagement activities aiming to improve cohesion across all actors in the healthcare sector. Allow me to especially recognize the diverse range of partners in the room, all eager to learn in and contribute to the dialogue. Thank you. Ladies and gentlemen, Chapter 4 of the Kenyan Constitution provides for the right to the highest attainable standard of health for all Kenyans. This underscores the importance of us as the ministry responsible for health, working closely with the Council of Governors and county governments, the private sector, development partners, and most importantly, community members to develop strategies that guarantee the delivery of safe, effective, and quality health services. A strong healthcare system results in a healthier population, which forms the basis of a productive workforce and a strong economy. This, in return, is a strong economic driver contributing to the growth of the national economy. It is therefore vital that appropriate policies are not just formulated, but that they are developed with strong input from all actors in the sector, both at the national and county level. Ladies and gentlemen, we are all aware of the declining development assistance for health, particularly from partners in high-income countries. This has been expected and indeed has been happening progressively for a while. While this creates short-term challenges for our health system, it presents unprecedented opportunities to go back to the DNA of what defines the African spirit, the Ubuntu philosophy, which simply explained means I am because we are. African communities thrived against the backdrop of individuals seeing themselves as being part of a larger whole, which meant working collaboratively towards a single set of goals that benefit the entire community. This is something we need to revisit if we are to make our health system deliver in the context of declining donor support. Ladies and gentlemen, It is against this background that the Kenya Kwanza government has pronounced its support for public-private partnerships. To facilitate more effective management of health services, finances, and information, the government spearheaded the enactment of 4 crucial laws, starting with the Social Health Insurance Act 2023, the Primary Healthcare Act 2023, the Facility Improvement Financing Act 2023, and the Digital Health Act 2023. Beyond the laws, the Ministry of Health and Council of Governors continue leading efforts to streamline health sector coordination and partnership policies. This includes developing the Kenya Health Policy Public-Private Collaboration Strategy and the Kenya Health Public-Private Collaboration Resource Guide and Toolkit, both of which are available to guide the establishment of PPPs in healthcare. It also includes coordinating the midterm review of the Kenya Healthcare Partnership and Coordination Framework 2022-2023, which we are presently undertaking to identify areas for improvement and develop a better framework to guide intergovernmental and intersectoral coordination across all actors in the Kenyan healthcare ecosystem. As donor funding reduces, the onus is on our collective effort to identify the most pragmatic alternative investment and financing mechanisms, and what better way to do that than through constant engagement and dialogue forums such as this one. Ladies and gentlemen, even as we celebrate progress in developing the right legislative and policy frameworks, we mustn't lose sight of the fact that the proof lies in the pudding. Without strong planning and execution, policies remain just that, policy documents. As a government, we recognize risk posed by low shared experience in designing and implementing PPPs, the absence of catalytic funding to enable PPPs, and inadequate public sector staff capacity to initiate, oversee, and manage PPP contracts at national and county level. Ladies and gentlemen, it is for this reason that this side event is particularly important to help us take stock of the healthcare investments and PPC situation in the country, explore positive and negative experiences and lessons gained, and recommit to establishing a shared purpose and roadmap towards institutionalizing healthcare partnerships in Kenya. We have seen the public-private sector pulling together and delivering strong value during periods of health emergencies and disasters, such as we had the case during the COVID-19 pandemic. Allow me also to add that great things also happen when national and county governments collaborate. And great things happen when the health sector collaborates with other sectors. Simply put, collaborations enable optimization of limited resources, allowing each concerned organization to deliver beyond its capacity. Great partnerships deliver great results. However, we mustn't always wait for disasters pulling together. We must take a proactive approach to engendering collaborations and partnerships within and outside the health sector. This is why such forums are important, particularly during periods of relative normalcy. Ladies and gentlemen, over the next 2 hours or so, we will hear from health system leaders and experts who understand partnerships and have experienced how these play out in practice. We urge that they share freely their knowledge and experience on investments and partnership and start moving us towards the right solutions. Rather than lamenting over donor withdrawal, I want us to discuss how locally driven innovations and investments can complement foreign catalytic funding and investments to power our health system. Rather than lamenting over limited treasury resources and growing healthcare needs, I want us to figure out how to plug budget deficits through partnerships. And rather than competing over limited resources and opportunities, I want us to cooperate better and build more opportunities for co-investments and mutual growth. At the end of this event, I would want to see a commitment from this congregation to work together towards making healthcare partnerships a reality at the national and the county level. Ladies and gentlemen, let us have a Homa Bay statement. I think it has just been signed. A show of resolve and commitment to establish a joint learning mechanism to build experience and expertise among counties to engage in PPPs. A commitment to supporting counties to learn from each other, a commitment to encourage counties to collaborate and co-invest in larger and more competitive ticket size items. And most importantly, a commitment to ensuring that no one is left behind and that the community voice drives open and transparent discussions directed at establishing new investment opportunities and PPPs. Ladies and gentlemen, as I conclude, allow me to extend gratitude to officers from my ministry, Council of Governors, and all convening partners here who have put in effort to make this a reality. Special thanks to Open Phences, Zero Malaria Campaign Coalition, Hector Kenya Healthcare Federation, Insight Health Advisors, the Embassy of the Kingdom of the Netherlands, and all other partners who have supported this initiative. Allow me to thank the Governor of Homa Bay County for hosting us and for continuing to show leadership in the health sector, both in her capacity as Governor of Homa Bay and as Vice Chair of the Council of Governors Health Committee. Last but not least, allow me to thank the people of Homa Bay for your warm welcome. It is now my pleasure, on behalf of the Principal Secretary, State Department for Public Health and Professional Standards, Ms. Mary Mudhoni Muriuki, ladies and gentlemen, to officially open the Devolution Conference 2025 side event on strengthening health investments and partnerships. Thank you.
Thank you so much. I think I'll ask CC Tharakanithi. We can now continue with our program where he will share his experience on public-private partnerships in Tharakanithi and the amazing work that they're doing there. Sure. Dr. Mwaniki.
Thank you, Dr. Orata. Your Excellency, Deputy Governor of Makueni, and all the other Deputy Governors, honorable members of the Senate, and the chairs of the Health Committee, colleagues, partners, ladies and gentlemen, good morning. My name is Gechoya Dhurakumutwadiara, and I work for the Tharakanithi County as a CC member for Public Health, Medical Services, and ICT. When I'm here, I cannot fail to mention that I have a very surprising and welcome deja vu, because in my earlier youth, I used to work around Homa Bay. Even when I was a medical student, in the 70s, we had community health programs. And when I grew a little bit older, I used to visit Homa Bay Hospital. I was even telling my senior colleague, Dr. Jikal, how we used to come over when I was working with the University of Nairobi, leading the teams on minimally invasive gynecological surgeries. So I really feel very much at home, and I'll proceed to my presentation. My presentation is on the collaboration between the Tharakanithi County government and a partner in strengthening laboratory services in our county. And it all started in August 2018 when His Excellency Governor Mulomi Njoki invited us to have a discussion with CHAI, that is a Clinton Health Access Initiative. August 27, 2018, where we held a meeting and discussed methodologies and procedures to make sure that we upscale the laboratory services in the Tharaka County. You know, we have come a long way because we now talk about evidence-based health services. There are times earlier in this country when we were all being trained as doctors to do what is called syndromic management of diseases, where we were taught in good faith by our teachers that certain cluster of presentations, certain clusters of symptoms, certain clusters of complaints by patients would most likely be ABCD. For example, if you have fever, headache, joint pains, and chills, the most likely thing would be malaria, you know. If you had this and this and that, then the likely would be even sexually transmitted infections. We had clusters, you know, that if you have pain when you are passing urine or burning sensation, or even some difficulty, it could be urinary tract infection, and which was a culprit, gonorrhea, you know. We gave gonorrhea a bad name because of the syndromic management of diseases. But over the time, we have now come to say that do not put a patient on treatment unless you have identified the cause of the complaints. And this was actually the basis upon which we started this journey. And at that time, we recommended that we need to, first of all, establish what are the gaps. What are the gaps in the Tharaka County in terms of the laboratory services? And we actually tasked the teams to go out and find out what these gaps were. And it was found that out of that time, 2018, out of 279,324 tests, laboratory tests that were ordered, only 93%, 108 tests were conducted. That is 25% of the demands. So you realize if you say 100 minus 25, it is 75. It is still 75 using base 10. So we had a whopping 75% of unmet needs in the laboratory services. And we knew the cause. We knew the cause, root causes of the gaps, and some of them were inadequate infrastructure and automation, underfunding of laboratory services, inefficient supply chain management, including poor quantification, delayed procurement, the insufficient human resource numbers, and also skills, poor awareness of the laboratory services, absence of digitization, to mention only a few. You realize that some of our health facilities did not even start as health facilities. I'm sure some of you, like Dr. Nyikao, you remember what Kenyatta National Hospital used to look like before. Because today people might think what they see is what there was, but it wasn't. We even had the old King George VI Hospital, and I'm doing this trying to point where it is, you know? So the current one is actually totally different. So even these facilities that are built in our counties, they started at a lower level where they did not incorporate the other support service departments, like laboratory services. So we found that these were some of the gaps. And when we assessed the required money to put up the laboratories, we found that it was estimated at 50 million shillings by then. And the priorities were identified as equipment, automation, reagents, and human resource training. Dr. Orata, what you put here is probably not matching what I had prepared in my slide, but anyway, I will probably verbalize what you have not depicted. So it was found that we needed some 50 million shillings to do that. But then the county government of the Rakanidi, and most of you who are present here, you know that county government of the Rakanidi and Lamu get the least revenue allocation from the national treasury. Those two counties, we are on the last bottom. Therefore, we could not afford to spend 50 million shillings. From where? And you know that 30 to 40% of county budgets goes to health. And then, even if there's a big chunk of the percentage of the county budgets, 70% of that is spent on salaries and emoluments, and therefore leaving almost nothing for development. So, how do we address this? We decided that for us to bridge this gap, we needed a strategic response and opportunities, and therefore we suggested, after very many discussions along the way, including other partners and stakeholders, that the public-private collaboration was the way to go. And of course, the benefits from that would be speed, innovation, sustainability, and risk sharing. And therefore, this model that was proposed, we actually consulted the lawyers. We asked the lawyers, if we are going to comply with the PPP, public-private partnership, how does it go with us? And the lawyers, advised us, look, why don't you go the private collaboration route, where you advertise for contracted services within a certain period, according to the Public-Private Partnership and Disposal Act, so that at least you can establish under that. And that is actually what we took. And therefore, we floated quotations for bids, and there is a private laboratory provider who qualified for the bid, and we started. Now, before we started, because it's a public institution, we wanted to carry along our politicians, the MCAs, and we took them through some of these deliberations, and they had their own input. We also did public-private partnership consultation with the public, telling them, look, we are proposing that we get a partner who is going to give us equipment, modern equipment, place them at no cost to the county, and this partner is going to provide reagents all the time. This partner is going to make sure that transportation of the laboratory specimens was going to happen from everywhere. And we decided, instead of starting all at once in every facility, we start only with one. We started with the county referral hospital, Chuka. And today, we have samples being brought to Chuka from other facilities. And of course, the idea is to make sure that the other hospitals and the other facilities will have this kind of arrangement. And we have so far found that it works. The way that the partner recoups their money is an agreement between the county government and themselves, and it is legally binding. We signed the contract, and we have found it working very, very well. In fact, at our hospital, we get referrals from the surrounding counties. And some of the tests that we could not be able to do, the test menu has rapidly increased. It has increased so much that, in fact, we are more or less in the discussion stage of how to up the game. Because, for example, some of the tests we used to refer to Nairobi, like the so-called immunohistochemistries and all that, even genetic, genetic tests, PCRs, polymerase chain reaction, etc. Things which were very expensive. And in fact, things that even as a country, just a few years ago, I remember there are some things we used to refer outside the country. Just the other day, we could not even do some histology, even at Kenyatta National Hospital at Aga Khan, and even at Mulago, and even at Muhimbili in Dar es Salaam. We could not. We used to refer to Britain. Just in our lifetime. I'm still very young, by the way, so I still remember. So I can see that, we are really going to continue improving, and we recommend to our colleagues and other county leadership that most likely this is the way to go, especially with the dwindling resources, which do not show any sign of expanding. We are now in the process of being ISO certified as a laboratory, offering institution. And so we encourage. I know we have so many other figures, especially with FIF, which is going to come on board also and help us. And I think this slide can be shared. Dr. Orata, you can share with the other with the members present, because you had told me 5 minutes. And and in case of any question, I'm available. I'm available to answer them. So I think I'll stop there, but also encourage that we expand the laboratory services, because even our patients will feel better if we manage them based on correct diagnosis. And in fact, there's I think a company which is going from county to county, talking about a less expensive model of laboratory and diagnostics and imaging. And I've sat down with them, I have listened to them, and I think those of you who are here in decision making, Her Excellency here, I think we may recommend taking that one, because it requires very little space, and it can actually be deployed in our dispensaries, in our level 3s and level 4s. In fact, for example, like radio imaging. Radio imaging does not even require building those great walls full of land because of the absorption of the X-radiation. The little machines which are even pocket friendly are not even radiating any emission, any radioactive emission. So I think I'm just trying to prime you when that man he goes with a team to explain what it is, because they are going to come to the counties. I think that is the way to go. So, ladies and gentlemen, thank you so much. I'll stop there unless my organizer here orders me to do something else. Thank you so much.
Thank you. I'm a consultant pathologist, so laboratory diagnostics excites me very much. As a Strathmore Business School, where I'm a PhD fellow, we actually evaluated what Tharaka Nithi is doing. A quick statistic is they had 30 tests. Now they can provide over 4,000. I understand people are coming from Samburu. Yes, it's a very big deal. They do very high-level molecular testing right there at public rates for public good. So it's an amazing, amazing, amazing project. I want to quickly roll over to invite the CEC Health Nakuru, Ms. Rose Mungai, to come and take us through Partnering for Effective Primary Health Care. Karibu sana.
Thank you, Dr. Good morning and all protocols observed. My name is Roslyn Mungai, County Executive Committee Member for Health, Nakuru County. I'm here to speak on behalf of my governor, Governor Susan Kihika. And before, I don't know whether we are running a video or not, there might not be time. You can advise me. We won't. Okay. In Nakuru, this is what we say. Our governor cannot afford to lose. She cannot afford to fail. Because I call her the poster child for devolution. First Speaker, Nakuru. Second Senator, Nakuru. Third Governor, Nakuru. Surely, she's got it figured out, right? And so, in terms of developing partnerships for the delivery of health services, we have a model. Our model is anchored upon, number one, ownership. We say to all our partners, big, small, far, wide, regional, local, international, that partnerships must plug into the agreed priorities for service delivery in health. And so we try as much as possible to involve all partners who are willing to work with us to improve service delivery in the annual planning process. We actually include columns in our annual work plan where we say which partner is committing to supporting what. And then when it comes to budgeting process, we are able to take into account the resources, most of which are in kind, not in cash, obviously, to fill up the gaps where partners may not be supporting. With the change in US government foreign policy earlier this year, and I think we've all been talking about the stop work order, one of the things that we benefited as Nakuru is because we had already pivoted before the stop work order. Sometime last year, we made a decision to call our partners together, both private and international development and the local organizations, and inspire them to walk with us the sustainability journey. Now I can see the presentation is there. It may or may not be relevant to what I'm saying. We asked our partners to kindly allow us to allocate resources otherwise earmarked for administrative purposes to avoid or to stop conferencing in hotels. I know that's not a good thing for revenue generation, but it's a very good thing for sustainability. So for 1 year now, all our meetings, workshops, trainings, conferences are held within our hospitals. We developed, and as you know, Nakuru has got a fairly good, I think a very good model for facility improvement fund. We developed lines within their budgets to cater for revenue generated out of conferencing. We are able to plow back that money into the development of our facilities. For example, in our level 5 hospital, which is a teaching and referral hospital, you would find the doctors training happening in a very small room, no digital capability. That is beginning to change because of the resources that are plugged back into it. Now, if you go back to the first slide, let me talk a little bit about how we onboard our partners. We have what we call a partnership committee. This partnership committee is chaired by the Director Medical Services, has all our directors, there are 3 of them, has all the unit leaders. So we encourage all our partners to have an entry meeting with the committee. That will be able to account for all the resources that are coming into the Department of Health. We are able to layer initiatives so there's reduced duplication. We are also able to develop an accountability mechanism. Her Excellency, the Governor has committed to 100% accountability and integrity. How will you be accountable for the resources that you're getting if you don't know what they are? So we do have a practice, which it has been traditional I think in the health ecosystem, where a partner may even get into an arrangement with a health facility. It is unacceptable because there has to be leadership somewhere. It is not about blocking creativity or innovation, but it is about accountability. It's also about scaling. So this partnership committee also has to be guided by the Office of the County Attorney. We sign MOUs with all our partners, or we endeavor to. Why? Because we want to make sure that everything that we're doing with our partners is anchored in some kind of framework. So our county attorney reviews all MOUs, sends them back to us, and we sign them off. Then we develop technical working groups, and we can move to the next slide. We develop technical working groups. If the partnership relates to maternal health, then we'll embed it in the maternal health unit. There are some examples that I put out here, and in case some of our partners don't see your names, kindly bear with me. But these have been very, very transformational partnership. With USAID Tujenge Jamii, Afya Ugavi, and I want to talk a little bit about USAID Tujenge Jamii. Because of the stop work order, all of us here who manage health programs within the counties had disruption one way or the other in February. But before then, we had sat with USAID Tujenge Jamii and agreed on a county-led, county-owned, county-managed process. So for example, the conferencing that I was telling you about, we had already stopped the conferencing in hotels. We had already developed a mechanism where the technical officers who work within the development part, like USAID Tujenge Jamii, were now replicated in the CHMT. So we reduced the amount of resources that were being spent within USAID Tujenge Jamii and used more of it to develop the capability of the county health management team. With Afya Ugavi, which, as you know, closed down a few, I think last year, we were able to set up the health products and technology unit separately within our level 5 hospital, and on and on and on. With Think Wellness and JPIGO capacity development that is practical in nature and not theoretical. And then let me mention Safaricom M-Pesa Foundation, because that is a private agency. As you know, the M-Pesa Foundation has been investing a lot in health. But what we try to do is to base the partnership on need. So for example, Her Excellency the Governor, Susan Keheka, has inherited a lot of stalled projects. And she decided to complete all of them, all the level 4 hospitals that were not completed, she's now completing. But as you know, it's twice as much, again, more expensive to equip a hospital than it is to build one. And so M-Pesa Foundation has given us equipment for one of our level 4 hospitals in Molo, I think to the tune of 50 million. What that means is that the governor is able to dedicate the other 50, the resources saved for Subukia and Gilgil and the rest of it. It's an excellent partnership, and I want to acknowledge M-Pesa Foundation for that. If you can move on. I think my predecessor, Daktari from Tharaka-Nithi, talked a lot about lab capability. I was just whispering to somebody who sat next to me from Makueni that as an unmedic, I get very, very worried about diagnostics. Because I say, if we can't get that right, what about downstream? So one of the things we have done 100% with FIF through our level 5 hospital is to improve our lab capabilities. We have established a state-of-the-art lab capability within our level 5 hospital, which, by the way, uses, I think, what they call robotics to analyze samples. We have collapsed all our labs. There are many within our level 5 hospital. We now only have one lab, apart from a mini lab in the maternity wing. So all the samples are brought together, disaggregated, and I think the machine conducts about 100 tests at a go. What this has meant, apart from accuracy, because the capability of the equipment is very high, is our patients are waiting less and less. Particularly, I'm really impressed with the diminished noise from our renal patients about the waiting period. We are now moving to Mira Kisumu. I've heard all about your drone capability, and we're hoping to move to that level. What we have done so far, and like I said, it's with that private partner, but 100% financed through FIF. We now are mapping all our labs across the 11 sub-counties to organize the clustering of the tests so that they can be transported through that drone capability to this lab and disseminated or communicated. We also are hoping to include the private facilities as also a way of generating revenue. I think I'll move, not talk about the rest. In terms of a few other points is a note as I end. It is critically important that all partners who wish to work within the counties First of all, especially the ones that are based at the program levels. I think we've talked about malaria, the HIVs, the TB, all those that are programs within the Ministry of Health. Communicate with the Council of Governors and shy away from directly contacting healthcare workers. Why? Because it is very important that this partnership committee of ours thrives, shows accountability, and shows results. So let me stop there, and I thank you all very much.
I understand you want to go and sample some fish in Homa Bay. You need to. A lot of good things for us. So I want to invite CC Kajiado, Mr. Alex Kilowa, to come and also tell us something about Kajiado. And then we have edited and modified our program for a quick panel discussion. It will be 1 minute so that we can all get ready for the closing ceremony.
Thank you very much. My name is Alex Kilowa. I am the CC for Health County Government of Kajiado. I will try to be very brief. Running a presentation on transforming sanitation in Kajiado, a waste to value. The question will be, why this topic? In Kajiado, we have a program on livable towns, livability of our towns, and we are also struggling with rapid urbanization in our major towns of Kitengela, Ngong, and Ongota Rongai, and therefore that is the reason why we chose this topic. And the main objective of this discussion and scaling up of innovations is to try and increase safely managed sanitation, reduce environmental pollution, and also integrate innovations into county system. So please go to the next slide. So we started by identifying the gaps we have from the sanitation point of view, which forms a critical component in public health protocols. One is the limited access to sanitation. The slides are not very clear. And in improved facilities, I have mentioned about rapid urbanization in our towns, the low sewerage systems, again, in our towns. And we went ahead to identify the solution. And at this point, I must appreciate partners like Insight Health Advisors and Sanivation, because we have walked the journey with them in scaling this solution, a county-wide inclusive sanitation plan, a fiscal sludge facility, and waste collection management. We must apologize about this kind of a procedure here, or the diagram, or the processes that are involved in separations of solid into liquid waste management, because that is what we went to do in Kajiado. Please go to the next slide. Financing strategy. Of course, public funding through the county government and national government, development finance, co-proposal developed with the Sanivation for development of finance institution, the PPP framework, right, what we are talking about. And we anticipate that through the separations of solid into waste, the liquid into waste, we will have revenue from the briquettes that will be generating. It's typically of what has happened in Nakuru. Rosalina, I must say, during these processes, we had the opportunity of visiting your treatment plant in Naivasha, and it's exactly what we want to do in Kajiado, in a place called Ngong. Expected outcomes are sustainable financing model to support constructions and operation, strengthen PPP models. I don't know why it's not very clear, but the key assumption is that the plant will be producing 300 tons of briquettes per month. Of course, the cost of the briquettes is 144 USID. The cost of goods include biomass that are readily available, so the cost of raw material is zero. And we also expect to receive 125 meter cubic of waste per day using that kind of an arrangement. Please go to the next. Partner dynamics. Partner dynamics and challenges. The Kajiado County has provided institutional support in terms of land. We have provided land to do this facility in Ngong. That is one of our urbanized town, and policy enforcement. Sanivation as partners, Inside Health Advisors have worked us this journey from capacity buildings of our members of county assembly to visits, like I have mentioned, been able to visit the plant in Naivasha in Nakuru County. Ololaisa Water and Storage Company will form critical part in terms of infrastructure integration. It's one of our water bodies. Of course, challenges will still remain: limited budgetary allocation, technical, economic, and social barrier to scaling up the waste management, low sewerage network across our municipalities, and ensuring that we are NEMA compliance, mitigating strategies, develop comprehensive business plan to attract funding, include stakeholders, workshops to validate and endorse the solution, and capacity building. Next slide. Current status of where we are with this discussion. I have mentioned that the county government of Kajiado, under the leadership of Excellency Governor Olilengu, has allocated land in Ngong Town to do this kind of a facility. Feasibility study. The county government has invested resources for a feasibility study to a tune of 6 million, and I think in the recent days we will be awarding for feasibility studies to be undertaken. Post-bidding evaluation is in progress, as I have said. Way forward, finalization of the feasibility study in Q1 of the 2025-2026 financial year, contract stakeholders workshop in Q2, sign, design, build, operate, transfer model in Q2 still, begin construction of in Q3, targeting completion 2027, monitor, evaluate to achieve 80% safely managed sanitation by 2030. Let me conclude by saying the earlier speakers have spoken about the donor funding shrinking, and we can leverage private-public partnership to have a health system that is resilient, responsive, equitable, and sustainable. Thank you very much. But even as I conclude, I still want to appreciate Inside Health Advisors, because we started this discussion by discussions around what they have done in Makueni County and Nakuru counties, and that is why we have also catch up as Kajiado County. So my only request to you is that we have done what we needed to have do as county government. I am really waiting for the next step of now rolling out this project. Thank you very much, and I'll be expecting any questions that will arise out of this discussion. Thank you.
Thank you so very much. Let's give all the CCs a big clap. A very, very big hand. I think, the transition was not easy, and they have taken it up, embraced it, and they've really run with it. And I really, really appreciate it. Of course, selfishly, Homa Bay. So we want to move into the panel discussion, which will be brief and different. And I want to invite up all the panelists. I think I'll just call them out. So I want to invite Her Excellency Lucy Mulili, Deputy Governor Makueni County, kindly come up. And then Honorable Dr. James Nyikal, Member of Parliament, Honorable His Excellency Senator Jackson Mandago, kindly come up to stage. Dr. Bernard Olayo, kindly come up to stage. Dr. Gakombe, kindly come up to stage. Dr. Nelson Gitonga, karibu sana. And finally, Dr. Ann Musuva. Professor Frank Wafula is going to take us through this panel discussion. Karibuni sana. There's a pin for the No Malaria campaign. Kindly pin it on yourself. It's a small gift. On your chairs, don't sit on it. We don't want to call the county director with accident and emergency. Karibu.
Thank you very much. And I'm told we only have 20 minutes for this. They've extended that grace to us. So we're going to do this in a very unique way. So first of all, thank you very much to my panelists, for making it to come here.
As Mike, please come and assist, and we can move the podium kindly.
Yeah, so as that is being moved, these people need no introduction. I think you've all come to appreciate who they are and the role that they play within our health system. So because of our reduced time, I want us to do this in a very unique way. You've been sitting here for the last 2 hours, and apologies if as part of that you were put to sleep at some point, but I wasn't. I really enjoyed the presentation. What I really want for you, so that we also have a couple of minutes to open it up, is just to give a reflection of what your thoughts are based on your experience. How can we make partnerships work and deliver, either from your past experience or from your expertise and knowledge on how this could actually work? And I'm going to start let me start at the center with Dr. Olayo. Maybe you can just share your reflection, because I know you've been working in the space of PPPs for over 20 years, and this is something that you're very passionate about. 2 minutes, Dr.
Yeah, thanks, Frank, for the opportunity. My name is Bernard Olayo. I'm a senior health specialist with the World Bank Group. I was part of an initiative that we were running across Africa called the Health in Africa Initiative, which was looking at how the governments can work with the private sector to improve access to healthcare. But before that, I think it's good to be back in Homa Bay because I've completed my tour of duty with the Ministry of Health working in this district then. So I left in 2005, 20 years ago, to do other things. So it's really good to be back and to see progress. In this journey, I want to place Kenya at a slightly different place. When I look at Kenya today, and I go to meetings where other countries are present, Central Africa Republic, Somalia, Uganda, and others, I see that we are in a much better position than these other countries. So we are punching below our weight. Because in Nairobi now, you have the epicenter of innovative financing, of PE funds. So the money is actually not the problem. So there's money to do all these interesting things. And some counties are doing some extremely innovative and interesting things. So the question is, what is stopping us from scaling up rapidly? And it boils down to a governance problem. So that is what is stopping us from moving fast. We have a PPP law, and I listened to the PP guy from Treasury because that used to be the obstacle, and it seems like they've cracked it. So now there's an opportunity for counties to move forward. So my reflection is that we have an opportunity to leapfrog. I listened 2 days after the stop work order came up. We were in a meeting on pandemic issues in Mombasa, and His Excellency President Kenyatta was the main speaker, and he asked us a very important question. Is that why are you complaining when the US government stops giving you their money? You are not a taxpayer there. They need to care about their people. You should figure out how to organize yourself. So I think where we are today, with the private capital available, both from the DFIs, that's the large international development financing institutions, and private capital available, if we just had some good manners and initiative, we can go far very fast. And there are examples from counties that were making presentations here today of things that are working that should be scaled up very fast. Thank you.
And thank you very much for mentioning counties, because that's why we're here. So, Her Excellency, Deputy Governor Mulili, what are your reflections? I know Makueni is a leading county when it comes to innovation and thought processes. Just listening to what's happening in counties and from your own experience, what are your reflections and how can we move this forward? Because this is a solution panel. It's not a panel to discuss challenges.
Okay. Thank you very much. I think listening from the presentations that have been made here, there is so much, again, to learn from each other, to learn from Tharaka Nithi, to learn from what I've heard from Nakuru, that conferences are now inside the hospital, learning from, I can't pronounce your name though. I don't know, it was into something. So, but counties can learn from each other. But again, we know we have so many partners who are in this ecosystem and space. So as Makueni County, we have held, for the last 2 years, each year we hold a conference with all the partners in Nairobi. All the partners, whether from health, from agriculture, from various departments. And we have seen actually people who come for the partners who come for the meetings, over 100 people. Over 100 partners, not people. And that means there's a lot of interest. And we have seen the value of partnerships in Makueni County. And I'm glad that they are helping us provide access to healthcare and having better outcomes in healthcare. So we appreciate the value of partners, but with the dwindling resources in our nation, it has been alluded. I was reading today's newspaper early in the morning, and I was reading about the infrastructure bond that was issued by, I think it comes from the National Treasury, by the Central Bank. I think you're related, all of you. And I was reading that I think it's about 300 billion from Kenyans, but they only needed 95 billion. Look at that money lying idle in people's, it's not idle, but it's available for something. How can you help us, design products or projects, that the county governments can be able to utilize? And I'm happy when I heard about the Tharaka example. And I know there are many examples that we can learn, that they can even have confidence in counties, that they can invest, that even private investors through PPP can invest in counties and be assured of a transparency and accountable system and not fear counties. So I believe from what I'm hearing, there is a lot to be done, and I'm happy that as we learn from each other and from this kind of discussions, I think our nation, we can really leapfrog to the next generation. Thank you very much.
Thank you very much. I mean, I couldn't have put it clearer. I could see Anne smiling on the other side. I know ThinkWell works a lot with counties
to expand such services and get much more efficiency. So if we look at, for example, the SHA reimbursements right now, I'll take an example of a cesarean section being reimbursed at 32,000 to both a public and a private facility. Now, for a private facility, that at 32,000, they'll pay their staff, they'll pay drugs, then, take care of theater costs and so on. But in the public facility, the biggest cost items, that is salaries and drugs, are actually already taken care of. And yet, we don't always see the same quality of services as we see in the private sector. So if I were a DG, and I need to expand services perhaps in even ASAL areas or, urban informal settlements, I'll really be thinking of how can I tap into the private sector, tap into their, capital and expand services instead of setting up all this and getting much more efficiency out of it. I think another thing that is really a low-lying fruit is in terms of backstopping the supply chain in Kenya. We know that it's still a journey to get KEMSA to where we'd want it to be. And with SHA right now, we are seeing facilities getting, a lot of funds flowing down to frontline providers and to health facilities. So I think one of the ways of leveraging the expertise of the private sector is in terms of developing framework contracts between counties and private vendors that can complement KEMSA during, when they have stockouts and so on. So there are very many opportunities for us to really tap into the private sector. But for this to happen, I think autonomy is really critical, that facilities have financial autonomy to retain the resources that they get from SHA, so that they can be able to contract private facilities. And they also need to be clear contracting frameworks. And, our colleague from Treasury has all that. So I think we already have the enabling legal and regulatory framework. It's really for us to step forward.
And I know we'll be coming to Senator Mandago and Dr. Ajikal on reflection on the potential legal barriers or opportunities. But I'd like to bring Dr. Gakombe, a wealth of expertise and experience in private sector participation in healthcare services. And I know as a private sector, you've sometimes felt aggrieved. We've read in the press about the struggles you're having, getting certain things working through the government. But now that we are a solution panel, what are the 2-3 things that you think moving forward here with this statement that has been made can actually create the change that we desire to see?
Thank you, Frank. A number of things. The first is for all of us, and especially those in government, to figure out that you will never have enough money for healthcare from KRA. It's just not going to be enough. It doesn't matter how you share the revenue. It's just never going to be enough. You have to be able to access private resources for operations and for CapEx. And KRA also gets money from private resources. It's just one of the channels. That's the first recognition. The second one is to recognize that unless incentives are tied to output, all the patients who come to your facilities are a nuisance. The longer the queue, and I worked in Kenyatta, the more of a nuisance it is, unless there is a correlation between my interests and the interests of patients. And that's where private-public collaboration becomes very, very useful. The third is that the entire health sector is a private-public collaboration, as it is. We just need to improve the legal framework and the governance, but everything we've done since independence, whether it's KEPI or COVID recently or whatever else, it's always been the private sector, the public sector, the non-state actors working together. We just need to make it work a lot better. For we in the private sector, money is extremely expensive. So we have one major ask. We can do everything you want us to do. We do the manufacturing, you don't. We do the production of equipment, the government doesn't. We are on every single pillar required to strengthen the healthcare system. It's only in provision that we share space. But everywhere else, and training, everywhere else, it's the private sector, right? So we can do everything you need done. All you need to do is keep your word and pay on time. That is our one very, very significant act, so that we can remain open and continue to supply software, supplies, people if you need them, everything that you require. My final point, Frank, is this. It is extremely important for all of us to look for the least cost way of doing things. Must you employ specialists, or should you pay per case? Must you employ specialists, or 3 counties can share capacity, right? Let's all look. The resources are not enough, so we all have a duty as Kenyans to look for the least cost way of doing things. If it's a county that can do it, let the county do it. If it's a private sector, let the private sector do it. If it's meds that can get medicines to facilities, then close KEMSA and let meds do the job. Let's not focus on ownership. Let's focus on output, on Wanjiko, Akinyi, and their children, because now they are old. We started talking about Wanjiko a long time ago. So she must have grandchildren now. So let's focus on the grandchildren who are now in our streets, so that we can give them the service that they need, rather than focusing on who owns what infrastructure. Thank you.
Thank you very much. And Senator Mandago, allow me to bring you in. And I know these are conversations we've had many times. First of all, Dr. said the basket is not enough. When food is not enough, it doesn't matter how many ways you cut it. It's not going to work. But I'm sure there are also other issues that perhaps through very strategic thinking at the leadership level, at Senate level, you can think about what are the opportunities, what are the things that can actually be unlocked. And I'm particularly interested in your views because you've also been a governor. So you've actually sat on both sides. So this is just your reflection. Are we backing up the wrong tree, or is there potential here?
Thank you very much, Dr. Just speaking from where chairman has left here. When the food is not sufficient, you look for the most nutritious that can take you longer. But I quite agree with the sentiments. I think from where we sit as a Senate, first, our work is to make sure that the legal framework is available and is enabling for private sector and public to work together. And I think that can be clearly seen in the recent laws that we passed that enables government to work with private sector in the provision of healthcare. What I would like to say is maybe we still need to have a lot of conversations between private sector and the executive, because we think we in Parliament has provided the legal framework for private sector and public to work. That's why we have a PPP Act in place. We have a Social Health Insurance Act in place that can pay for services used by the public, both in public and private facilities. The conversation should be at the implementation level. What is it that the executive in the county and at the national government level can do with the private sector in terms of implementation and collaborate? Number two, one of the things that I think, in my view, has been a bottleneck towards having a successful public-private sector collaboration and initiatives is the transparency involved in the processes, both from the government position and also from the private sector. There's a lot of hoarding of information and resources, both in private sector and government. And I say this because, for example, you find a manufacturer who has a good product, has only one agent in the entire continent of Africa, who everybody is running after. That agent is not willing to share that agency with any other agent. So you need him in Tarakanidi, you need him in Omabe, you need him in Uasin Gishu. He is not available. He is holding into a very important innovation that would have been easily shared and spread and used when we are looking at the least cost provision of service. So I think one of the things that we want to encourage is transparency in all these processes. If you look at where we picked, but we must also acknowledge that there is significant progress from the time we started with devolution in 2013 to date. There is significant progress in terms of public-private partnership. When we did the mess equipment, we had a lot of challenges with that project. However, it significantly opened the eyes of public and government to the opportunity available in public-private partnership, to the extent that services that you would find only in designated hospitals would now become available. If we look at the current arrangement, there's been more discussions with county governments in the placement of equipment. So we are improving. I think if we could enhance our conversation, and I really want to hire the Minister of Health, representative of the PSC here, and Council of Governors, now to work closely in terms of implementation. The legal framework, I can assure you, Parliament, we have done our bit, and any other time that you require parliamentary intervention in terms of legislation, you only need a petition or to write to us or appear before our committees, and we are more than willing to take action so that we can create that enabling. Finally, even when we collaborate and work all these things, I've been telling my friend here, Wafula, that now he has to get this Human Resource Act in order. Because clearly here, the CECs have said the resources in the counties, more than 50% go to health. Of that 50%, 70% goes to recurrent, which is salaries and emoluments, which is good because you will never deliver health care without personnel. Now, it's also our ask here in Omabe that the human resource in health, please, go slow in salary increases every year.
Otherwise, there is no time. We are going to avail the resources for systems, you know, and for improvement of these other sectors. So let's have a balance between our request for emoluments and also for improving the facilities that we need to deliver healthcare. Thank you very much.
Thank you very much. So Nelson, you and I have walked this journey for a long time, and you're a seasoned expert when it comes to scaling private ideas through public channels. I just want you to tell me 3 things very quickly that you think are best case, basically path openers when it comes to getting that success to work, before I bring in Dr. Nikal to wrap this all up for us. Thank you.
Thank you, Prof. I can see you are a teacher. 3 things. My name is Nelson Gitonga. I lead the IHA team, which has been working on private sector engagement, health systems, and innovations. 3 things. The first thing I wanted to mention, and again to support and build on what my colleagues have talked about, is that we need structured dialogue and engagement between the public and the private sector on an ongoing basis. And I'll give a reason why. Dr. Gakombe here knows we spent many years setting up the ministerial stakeholder forum, presidential roundtables. I don't know that we have governors roundtables to really hold each other accountable. I've heard Senator Mandago talk about transparency. How do we hold each other accountable for the public-private goals that we have set before us? How do we identify which partnerships really will give us value for money, value for health, and are in the public interest? That discussion needs to happen. Second thing I would mention is the role of innovation. Dr. Gakombe has mentioned about least costs way of delivering care. Innovation is about improving the impact or the outcome of our health interventions while using the least amount of resources available. But innovation is also about providing care that is acceptable, that is good quality, that meets the felt needs of the communities we work with. So we need to think very innovatively when we talk about partnership. We should not partner to bring in mediocre and old ways of doing things that are expensive, that are very costly. I listened to Tharakanidhi CC talk about the lab work. In the old way of doing things, we would just have looked for money to put up a big flashy lab and have an opening ceremony and call the press, and after that the thing will remain a museum. But you have seen what they did. They didn't take that route. They took the route of going directly to procuring the service in a cost-effective way. So we need to think very innovatively about our innovations, and especially for health. Unlike other sectors like roads, energy, power, that are very heavy on infrastructure, I want to make the case that for health, we need to be heavy on service. Yes, we need to be heavy on service first, not infrastructure. It is very tempting to jump into huge infrastructural PPPs. Bernardo Layo is here. He knows about the Lesotho major PPP hospital and all the research that has been done about the value for money and value for health from such projects. For health, we really need to look at service. And I've had very interesting examples from the CECs. We need to focus there. And finally, let us involve frontline healthcare workers and communities and households in identifying priorities and solutions that will really make a difference in their lives. Thank you.
Thank you very much. And so just allow me to bring in Dr. Nikal, our senior, our teacher. He's been a teacher to most of us. And I'm just going to give you this as an open point for you to reflect. Having listened to all this, just what are your thoughts about where we're heading?
Well, my thoughts, and you say what we have experienced. First of all, I started work here in Homa Bay as a medical officer when it was clear to us that if a woman got into labor at 2 o'clock, in Sindor, in Beta, she was likely to die. And we even had to have boat ambulances, motorboat ambulances. And when I became Director of Medical Services, we said some of these things should be corrected. And we had to get the hospital in Sindo, the hospital in Migori. Before then, the only hospital in Migori was Ombo, which was a private hospital at the time, and the hospital in Karachuonyo. What I learned during that time is that the health sector is one. The distinction that it is private and public is just because of management and the source of funding and a little motivation of interest in the part of the private sector. That money in the health sector, we need to put it all together, whether it is in the public sector, whether it is in the private sector, and how can we best use it. If you do that, we actually have enough money. If you do it, what in the health sector and what in the private sector, what happens with inefficiencies and also self-interest, you will find that the cost, at least before, in the in the private sector was so huge that what would treat one person in the private sector would have treated many people in the private sector. When you come to the private sector, the inefficiency is so much that the money that is lost in the inefficiency. So that is the first thing. So people at the high level like us should actually realize that whoever can do it best should do it. I think that is the essence of that. Number two, what I've realized, that health sector, like any other service, is actually delivered through politics and business. Whatever you do, those two things will actually run it. And what we must try at all times as human beings, guided by laws, is that business interest and political interest can only be tamed by us in the health sector, so that business interests and political interests do not erode the services that we give to our people. Having said those two things that are very difficult, my other realization is that we actually work in silos. The counties work in silos, and I think many people say that here. Then you also find that the private sector is also working in silos. And then you have another silos now in the public sector, not county to county, but national government and county. Because all these are partners. So in my view, what we really need to do is actually get partner coordination mechanism. And there are various levels of this partner coordination mechanism. The first and the biggest one is actually between the national government and the county government. Because even there are a lot of coordination that is required. If we get that working, then we need another coordination of county to county, because we have had 3 experiences here which actually need to be passed through to all other counties. So how do we get that coordination working? So what is useful in one county is done in another county. Homa Bay has shown us about malaria dropping from 17 to 3%. That's something that actually we realized in 2005, that if you did IRS, indoor residual spraying, twice a year across the country, you do it. But it was done once a year in seasonal transmission areas, what was used to be called island malaria areas, once a year because of the issue of money. So now the partners have come, worked with Homa Bay, and shown that if you do it twice a year, you drop malaria. So that, how do we then make that work everywhere? And partners in the private sector. How is it that you did it in the partners did it in Homa Bay, a little bit in Migori, with fantastic results, which we are not know about and nobody is using. But we were just told here that they actually in the PP law, there is provision even for counties. That is something that we should take into consideration. And then it can be made further to work. Take what is in the PP law at the Act, the National Act, and how do we bring it at the county level so that the counties can actually even have their own partner arrangements in a legal way. So I think that partner coordination mechanism is extremely important in what we can do. And then how do we use the law that is nationally available and bring it to at this level? If we do that, the partner coordination mechanism, it will be okay. Because even if we go into manufacturing, you are saying of holding, we have laws, TRIPS, trade-related intellectual property. Yeah, there are those laws that will actually can make us get drugs from another country by law. So I'll summarize by saying we must realize that we are in one sector, we are serving the same group, get the laws that will coordinate all of us, national, county, then county, private sector, and national private sector. In Parliament, we can actually do that. Again, remember, Parliament not only makes laws, but Parliament also appropriates money, even for the county. And I'll just give an example, I know time is up. This time, we actually worked together and we got money for UHC. We needed 13 billion. We managed to get 6.2 to start with. Money for primary health care, we needed 60 billion, is what we are told we need. We were able to get 13 billion, which again we agreed on. Money for the employment of interns, which was a big issue. We wanted something up to 6. We were able to get 4 billion, and there was a lot of cooperation. Now, those monies are there. But all of them, the primary care money, the UHC money, the internship money, the level at which that money is going to be most effective is at the county level. The primary care which would make us be able to give level 2, level 3, and outpatient out of charge. As of now, me and him, we don't know how it is being worked out and how it is going to make that work. So the counties must really get themselves and say, when this money comes, how do we use it? So I think partner coordination, and look at partner in a bigger sense than just the private sector and the public sector.
Thank you very much. Dr. Noel wants to box me, and I know it's partly because the program started a bit late. Allow me to just give a 1-minute reflection of what this conversation has been about. We started by listening to Dr. Olayo, an expert in Africa. I know you've worked in multiple African countries in public-private collaborations. His quick reflection was that we are way ahead and we are wasting time. We should be providing more leadership. Her Excellency Deputy Governor Lucy came in and she actually emphasized the value that they have seen in Makueni County as an executive and what that actually leads, in terms of the direct impact on the public. And then Dr. Musuva came in and talked about the opportunity to optimize resources that are there within the county systems to actually be able, to get some of these innovations in. Dr. Gokombe was very direct in terms of you don't have enough money. And I know a lot of people here are public sector, counties. The bad news is you don't have enough money. And I think even if it's tripled, it will still not be enough. So it's in your interest to figure out how to optimize that by getting what else is in the other sectors so that it can all work towards a singular goal. Nelson talked about, the experience that they've had, and Insect Health Advisors and have been working a lot on supporting counties, particularly in the Lake region, but also other counties like Kajiado, to scale innovations through public systems. So that is actually opening a way, because innovations tend to scale through markets. So people have to go and buy at the market. But what if you bring them to public systems? Then people don't have to spend a lot of money. So he talked about what are the important lessons through that. Senator Mandago has given us a reflection, and he actually finished by reminding us that even though the money is not enough, we still need healthcare workers. But the problem is, if you keep asking for more money, and it's challenged me wearing the other hat of healthcare workers to figure out on how to keep all these things balanced. But he emphasized something very important that we must not lose: the fact that the trust architecture is extremely important, and transparency in these processes is what. And actually, we've seen the public pushing back on PPPs, not because they are bad ideas, but because there's something secretive about them. So that actually came out. And last but certainly not least, our leader within the sector, Dr. Nyikal, reflecting back on what this actually means over the years and what the opportunities are for actually getting this to work, and underscoring something that is part of why we are having this conversation, which is a proper coordination framework to actually get this happening. And that's not between national and county level, public and private sector, one county to another, but also even within the county themselves. And Dr. Nyikal would agree with me, and we're discussing this morning, primary healthcare would be sorted if the Ministry of Water did things better, if the Ministry of Roads did things better. So even public, and I know, Your Excellency, you're very passionate about public collaborations because you've mentioned that in the past for us. So all these opportunities actually create a lot, and that is why we're actually here. So ladies and gentlemen, join me in giving a hand. Sorry, Dr. Nyikal, I cannot say no. He wants to say something quickly.
What I want to tell you, if you look at the health sector, we are private, public. But in a country like Japan, it is the insurance system that actually pays the private sector and the public sector, so that if SHA were to work the way it should work, then all the sectors will be paid through that money. And it is possible if we want it to work.
Thank you very much, Dr. Ali. So join me in giving them a hearty clap. And I'll hand this to Dr. Noel because I know we have some small tokens for you, just a small appreciation. And for me, it's to say thank you for your patience. I know this overran a bit. We don't take that for granted, and we are very grateful. So asanteni sana. A special thanks to Liz and Abel. I know, we ambushed you, but you've actually stepped up for us. So thank you, and thank you for everybody else who's participated in this as well. Thank you.
Thank you. So Frank, I don't want you to leave. I'd like you to hand over gifts to our panelists. Then we'll have the CEO National Youth Council hand over to the CECs. So Frank, maybe we can come to the front. I can ask each one to come. Maybe I can start from this end. Dr. Gakombe, you'll be receiving a gift. So Frank, come this side. Oh, Frank, you can come this side. Yes, near us. Yes. And then we can give Dr. Gakombe. Let's give them a hand. Thank you so much for contributing towards our discussion today. Yes. His Excellency. Yeah. So panelists, don't leave the stage yet. Thank you. Thank you so much. Dr. Nyikal, karibu sana. Gift. Dr. Olayo, karibu sana. Dr. Nyikal, kindly don't leave stage. We want a group photo together. Yes. Her Excellency, kindly come. Thank you so much. Dr. Musuva, karibu sana. Gift. Thank you so much. And finally, Dr. Gitonga, karibu sana for your gifts. Dr. Gitonga and Open Phences, he's the team lead of Insight Health Advisors. We've been long time standing friends. And this was a partnership between IHA and us. Thank you so much. So maybe I can kindly ask the panelists to come to the front with our signed statement, we could take a picture here next to Frank. I think Frank is being moderate, but he's the chairperson of the Kenya Health Human Resource Advisory Council for Kenya. So he's figuring out human resource in healthcare for Kenya. He's also a professor at Strathmore Business School, Strathmore University, and the team lead at Open Fences. Karibuni sana. Thank you so much. You may take your seats. I want to invite the CEO, National Youth Council, to come and gift our CECs for doing an amazing job and doing their presentations, just to bring to light active current partnerships that are actually working. Kindly come. Yes. So I want to invite Ms. Rose Mungai from Nakuru to come and receive her gift. You can come up on stage, please. Yes. Ms. Mungai, Rose, I saw standing up. Maybe I can invite Dr. Thuraku from Tharakanithi. Thuraku. She's coming. It's okay. Thank you so much. Can we take photos kindly with the CC Nakuru? Asante sana. Mr. Alex Kilowa, please kindly come up for your gift. Yes, please stand aside. We'll take a group picture together. I'll also ask Professor Frank to come back up on stage for the CEC picture. Yes. Thank you so much, CEC Kajiado, Mr. Alex, for your presentation. Dr. Nthuraku, he was my boss when I was a young doctor and continues to be my senior colleague. Karibu sana. It's been amazing working with him and his big team. Maybe the Akanithi team, you can wave. Those are the implementers of the lab diagnostics. I am a pathologist. I love the work they're doing. Asante sana. And finally, my CC, Homa Bay County, Karibu sana, for taking us through, hosting us, bearing with us, and making us comfortable. And we finished all your hotel rooms. We need to construct more economic zone. We need more hotels. We have hotels. Thank you so much. Some of us were coming home. We enjoyed being home. Thank you so much. So I'll ask, there's a special gift for Engineer Kefa Seda, the Head of Directorate, Public-Private Partnerships. Thank you so much for giving us a very important talk on how Treasury healthcare sector is supported by his directorate to enable our work go further. Open Fences will want to collaborate directly with his office to achieve PPPs for health. Thank you so much. So I'll ask everyone to kindly step forward so that we can take a picture and then we can do gender balance. Tulisema 1, 2. I can go there. That side, yes. So, yeah, so I want to, Engineer, I think we can stand with the CC in the middle. Our host, CC, can also come. Yeah. And then you can come in the middle. Yeah. She's our host, CC. I'll go to the end. Oh, right. Thank you. Thank you so much. I want to hand over back to our moderators to summarize so that we can close. 1 minute.
Thank you. On behalf of the National Youth Council, we'll be having a youth engagement right after this with Abel and Liz at the Youth Pavilion. Please come and engage with the young people and tell them a little about malaria. Thank you.
Thank you. So just let's wrap it up as Liz and Abel take us through the summary. I hope we have more jokes and games. Thank you.
Thank you. Thank you so much, Dr. Noel. Hi, everyone. I know it doesn't feel like it was a session. It feels like it was a capacity building workshop, right? And we all feel very well energized. There were lots of learning, lots of insights, lots of great presentations from the great work that the counties are doing. We noticed and we really imbibed on the knowledge and wisdom from our excellent panels and thought leaders that were here. So ours is not to belabor the point that has been really well articulated by all the experts who are on stage today, but to really thank you, the audience, for your time. I mean, we've been here for a very long time, and I just want to do a brain teaser to see if you're still okay. Ama, you need some kahawa, some cappuccino, or some fish. I want to ask a question. So my background is in law, and you know the law of tort. So if you have a mango tree and the fruits grow on your neighbor's, the branch extends to your neighbor's property, who owns those mangoes? So I'm going to ask about a peacock. I have this peacock. It went and laid eggs in Abel's compound. Who owns the eggs? I hear Abel owns the eggs. Anybody with a different opinion? I'm very shocked. These are health experts in the room saying they're Abel's. Who believes they're Abel's eggs? Please raise your hand. I heard he was right. What did you say? They're peacocks. Peacocks don't lay eggs. It's the peahens that lay eggs. But we really thank you for your time. Really appreciate everything. I hope you can join us at the youth. Over to you, Abel. Thank you so much.
You actually got me there, Liz. Kumbe mimi ni bure. Oh, thank you so much for sitting for how many hours? We started at around 9?
Yes.
Wow. Almost 3 hours, man. Kazi safi sana. Bless you, bless you, bless you. I'll be a bit biased today, mutaniruhusu. But my biggest take home today, aki poleni, I'll be biased, poleni, is the fact that the malaria prevalence in this county went down from 17% to a very low of 3.6%. Yani, hiyo ilinifurahisha, wacheni tu niwaambie. That's beautiful. Also, I've learned that as we are seated in our couches huko in the city, we don't really get to know what you people in the counties are doing, but yo, splendid job. Keep at it. Keep at it. Endeleeni na moyo huo, tusichoke. The end is near. Sawa wadau. Thank you very much. God bless you. See you on the next one.
Thank you so much.